Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time. We'll try to get them answered at the end of the webinar. At this time, let me introduce our speaker for tonight. Repeat speaker for us with these webinars. We're really excited to have Dr. Alqadoumi with us again tonight. We have a huge crowd online to listen to Dr. Alqadoumi's message tonight. Really excited about the presentation. Dr. Alqadoumi graduated from the University of Jordan in 2012, earning his first DDS degree. Dr. Alqadoumi continued his dental education in the United States, where he attended Loma Linda University in California. In 2016, he received his second DDS degree and continued his postgraduate training at the Loma Linda University, where he received his MS degree in periodontics and implant surgery. Dr. Alqadoumi is an assistant professor at Loma Linda University in the Advanced Periodontics and Implant Surgery Clinics. He is also a member of the American Academy of Periodontology, Academy in Osseointegration, California Society of Periodontics, American Dental Association, and numerous other dental organizations. Outside of dentistry, Dr. Alqadoumi enjoys watching sports, playing soccer, traveling, and spending time with his family. With that, I'm going to turn it over to Dr. Alqadoumi. Dr. Alqadoumi, thanks again for joining us tonight.
Thank you very much, Russ, for having me, and everybody at Osteogenics for having me again. It's a true pleasure and honor to be with you here tonight. Or morning time, or whatever time you're watching us. So tonight we're going to discuss a topic that I like and I enjoy, and I even decided to make it my master research when I was in residency. So we're going to talk about crestal sinus augmentation using a novel bone putty, and that novel bone is the Nova bone. And we're going to talk about sinus augmentation, what do we do, and multiple learning objectives that I would like to touch on today. So when we discuss sinus augmentation, it's a procedure that we do when we have a deficient bone in the posterior maxilla and we're planning to place an implant. And that vertical deficiency will require us to do some sort of sinus augmentation to get more vertical bone height to place implants. And depending on how much bone below the sinus floor, either we can do a lateral window sinus augmentation or we can do a crestal sinus lift. So when we talk about the lateral window, this is originally described by Tatum in 1977, but it was not published until 1980 when Phil Boyne and Robert James talked about it, where we access the sinus cavity through the lateral wall. So this is more invasive. We may see more complication when you compare it to the crestal sinus augmentation. But it has some benefits that you have direct vision, direct access to see. And usually we say in research that this is indicated when we have less than 5 millimeter of residual bone. Now remember, when we gonna discuss cases and talk about this today, I want you to remember that we have literature that's from the 70s and the 80s and the 90s, and a lot of things, a lot of improvement that happened nowadays in the biomaterials that we use, in the drilling system that we use. So we may do some changes and some modifications to what we know from the literature. So this is an example where you have 3 millimeter almost of residual bone. We're gonna go for a lateral window sinus augmentation. Not our topic today, but just to kind of give you a hint of what we do. We go to the lateral wall of the sinus. We make our osteotomy. We create that window. We elevate the sinus membrane all the way to the medial wall. And then we pack our bone grafting, our biomaterials. We place collagen membrane and we suture back up. Okay, so in this, we prepared the site to receive later on implants And we can see that we have gained, let me see if this video plays. We have gained a vertical height that will allow us to go back in and place the implant comfortably with the length that we need. So we go back in, we place the implants in the ideal prosthetic location. And this is how we send the case back to the restorative dentist. And this is healing after it's ready, and this is 3 years after. So this technique allowed us to get more in the vertical aspect of increasing the bone below the sinus floor, as we can increase and elevate more than what we basically get with crestal sinus. But now when we talk about crestal sinus augmentation, 1994, Summers introduced the less invasive procedure where we do it with simultaneous implant placement. And this is done when we have a residual bone of 6 millimeter or more below the sinus floor. So remember, as I mentioned, this was what recommended back in 1994 to have 6 millimeter as a cutoff to go for a crestal sinus augmentation. Lateral window, we are saying 5 or less, we're going for a lateral window sinus augmentation. So we elevate the sinus membrane, and I'll talk more in details about it, with osteotomes, and we add bone graft that act like a hydraulic plug to lift the sinus membrane, and we place the implant simultaneously at the same time. So when we talk about crestal sinus augmentation, I want you to look up the literature. We have tons of techniques out there that people try to do, to invent, to come up with, to make life easier when we do crestal sinus augmentation. I'm going to touch on some of them today, but mostly I'll focus on the Summers technique with osteotomes and the osteodensification technique. But to give you a quick summary, 1994, Summers, what they proposed at that time is that we are drilling up to 1 millimeter below the sinus floor, and we're breaking the bone of the sinus floor, and we keep it attached to the sinus membrane. So we place bone graft, biomaterials, we break the bone, and that bone will act like a hydraulic plug to reduce the pressure on that 1 millimeter of bone that we left. And we elevate the sinus and we place the bone graft at the same time. Some modifications happened. If you want to do future site development, prepare the site to come later on to place the implant if you're not doing simultaneous implant placement. There is localized management of the sinus, this technique, 1999. Special implant drills that Koski in 2000 they came up with. Bump technique, DASC technique, a lot of techniques out there that have talked about possible, how can we do the crestal sinus augmentation? Now, the internal sinus manipulation is introduced by Yamada, and I kind of like this one, but it's very, very technique sensitive. But I'll show you how I implement that in how I do the crestal sinus augmentation. But I want you to see where we have, in this technique, it is exactly like a submarine telescope, that this telescope will get out of the water and you can 360 look around to see your surroundings. And this is how that instrument, as you can see here, and thanks to Dr. Abdul Karim Ahmedan for these videos, from those are sinus endoscopy that were done during his research at Loma Linda. So that shows you how this technique is trying to release the sinus membrane through the osteotomy and get that release. Now, as I mentioned, this is very technique sensitive, and it may have some problems with perforation. As you can see, the site that on the right side of your screen where it says perforation, that's when we're going to have the perforation at the end of the video. I think I don't have the luxury to fast forward it, but give me a couple of seconds and you will see the perforation as it happens. But generally speaking, I like this because it allows to break that seal between the sinus floor and the sinus membrane. And by discussing the biomaterials that we use, that will help us to get more elevation than what we usually get. So yeah, I see. Thank you, Steve. I see you're trying to fast forward that. If you can go towards the end, yep, right there. Go a little bit back. Yes. So now you can see how that instrument perforated into the sinus membrane. Now the challenge is clinically, how much are we able to detect that perforation? And we're going to talk about that more also. So there's a balloon technique, also introducing a balloon inside the sinus cavity with saline pressure and try to elevate the sinus membrane. Again, same thing, hydraulic pressure, physio-lift. So a lot of techniques that have been proposed and introduced. But I want to talk a little bit more today about the osteodensification technique by Salah Weiss with the Versa drills, which I believe, in my humble opinion, the osteodensification drills and the Nova bone has been both revolutionary in the huge change in the crestal sinus augmentation technique and how much we can do and how much we're able to push the limits. But still, we're going to need to understand biology and know what we're dealing with in order to be able to do that. So, for example, this is what they recommend when you have, let's say, for example, a 5 millimeter of residual bone. We use some special drills that condense that bone, and at some point you will perforate and break that sinus floor wall to get into the sinus cavity. And you can extend up to 3 millimeters. That's by their recommendation. And I'll tell you what I like to do. And you're working in counterclockwise. And then you place the biomaterials and you place the implant simultaneously. Now, when we look at studies that looked at implant survival when you do the osteotome technique for crestal sinus augmentation, we see 95 to 96% of success rate, which is good to see. But we don't have a lot of studies that talk about the incidence of membrane perforation when you do that technique. For example, we have a study by Tan et al. They talk about possibly 0 up to 21% of a perforation that happened during crestal sinus augmentation. But they mentioned that the most or difficult thing is to be able to detect is it's difficult to see what you're doing, and you have visual limitations. And if you're someone who used the osteotome technique, you will see that you have limited access to see. Most of the time, we're just seeing blood coming out of the osteotomy. So there's a lot of limitations to be able to see. But nowadays, with the osteodensification technique and the Versa drills, the beauty is that you get a nice, clean, round osteotomy. The bone is condensed, and you can see the sinus membrane clearly. So I think nowadays, 2024, we're able to detect and see perforations more than what we were able to see before. So some considerations and important things that I look at as planning my case for crestal sinus augmentation. So by now we know that what is sinus augmentation, what are the types, when do we do lateral window, when we do crestal, what are the techniques out there, and we're going to focus now, if I have a case, how do I plan it? What are the things that I would like to look at to make sure that we have correct planning for this case? I would like to know what's the membrane thickness. And Lim et al. And a lot of studies talk about that the lowest perforation when we look at the crestal sinus approach, and we're talking about crestal, not a lateral window, is when we have 1 to 1.5 millimeter membrane thickness. Surprisingly, more than 2 millimeter and less than a millimeter, you see also higher incidence of perforation. So the happy medium is when you have 1 to 1.5 millimeter of membrane thickness. Anything less than that, anything over than that, increases the risk of perforation. Another important factor that to me is the cornerstone of crestal sinus augmentation or elevation is the sinus floor angulation. this gets a lot underrated and not paying attention to it. And I want you, when you do your cases or cases you've done, to look back at it and see, do you agree with what we found and what other researchers found in their studies, if that's an important factor or not? But Cho et al., they looked at narrow sinus anatomy when the angle is less than 30 degrees between the lateral and the medial wall, we see higher perforation rate up to 62%. And when it is between 30 to 60, 30, I'm sorry, or 60, you can see 28%, and it drops to 0 when you have 60 or more. Now, think about it in another way. When we look at the palatonasal recess, if it's less than 30 degrees, we expect to have higher chances of perforation on that medial wall as we're doing lateral sinus augmentation. So what's the difference? If that angulation is on the lateral wall, on the medial wall, I'm sorry, or if it is on the floor of the sinus, of the sinus floor. So this is a very important aspect to look at. Also, in our research, and it's under review for publication now, we see a higher chance of perforation and more localized pattern of vertical sinus augmentation when we have a narrow sinus width and more acute angle of the sinus floor. So Dr. Garbacha, now I'm going to discuss a series of human cadaver studies that we've done at Loma Linda, where we worked on human cadavers, fresh human cadaver heads. And in this study, she compared 3 different crestal sinus elevation techniques. And she had a residual bone below the sinus floor of 5 millimeter, and the perforation rate was about 40%. And that tells us that to push the limit beyond the safety margin of 4 millimeter of lift, because remember, when we say we would like to have a minimum of 6 millimeter as Summers recommended, which means you need this 4 millimeter lift, if you push that limit, you increase the chances of perforation. Now, another study by Dr. Abdulkarim Mahmeidan, where here he wanted to push the limit more. He wanted to push the membrane 6 millimeter and having a residual bone of 4 millimeter, okay? And the incidence of perforation went up to 47%. So when we compare it to Garbacha's study, where she had 5 millimeter residual bone, and here we have 4 millimeter, it makes sense that the incidence of perforation can increase. And they did also, one cool thing is that they took CBCT scan after the procedure was done, and they found 60% accuracy of that CBCT in detecting perforation. And I'll show you a case today to kind of open your eyes for that. So CBCT is helpful, but at the same time, you may not be able to detect that perforation. Now, I'm talking about incidence of perforation. I'm not talking about incidence of complication. I'm not talking about how clinically that will cause a problem, because you may have implants in the sinus with no issues, and you may have implants without a perforation and cause a problem. But we're looking at what is that incidence of perforation, and it may cause some problems, but not necessarily. So in a multi-center study, and this was a very intriguing study that made me think about my research, Salah Weiss in 3 centers, they reported of 222 patients, they did crestal sinus approach using the versadrills or the osteodensification technique, and the average of the residual bone was about 5.4 millimeter, and they were able to get 7 millimeter increase of the vertical height of the sinus, which is great. That this is a very nice study. They had no sinus perforations, no implant failures up to 5 years follow-up. So I decided that I would like to do a study, and it's a human cadaver study where we got human cadaver heads, and those are fresh frozen cadaver heads, which means within 24 hours of their death, they got frozen. So they mimic and maintain as much as possible, as close as possible to the living human being from tissue texture, elasticity, and everything related to that. But the difference in this study that we did not do endoscopy, a sinus endoscopy, like how Dr. Al-Medan did or Dr. Garbacha, but here it's the first study that we cut the cadaver head with a metal saw, in an axial direction to expose the sinus cavity, so we're able to see exactly what's happening as we're drilling, what's happening as the implant is being placed, and as the bone graft is being placed. So we had 10 cadaver heads, and we did a split mouth where one side received osteotome, the other side received the osteodensification technique. And we had the same surgeon, an experienced surgeon, so we don't have that variable in the game. We used the same bone graft, which was the Nova bone, and we used the same implant system for both sides, and that was neobiotic implants with tapered geometry. And some may ask why you use tapered, because the previous two studies, we used one tapered and one parallel-sided implants. Still, the incidence of perforation was not different when you have a tapered or parallel-sided implant. So here, the aim of the study was we wanted to see what is the incidence of perforation when you have 5 millimeter of residual bone, okay, when we compare both techniques. Second is we wanted to see, when does the perforation happen? Does it happen as you're drilling with the Versa drills, or when you're preparing with the osteotomes? Does it happen when you're placing the bone graft, or does it happen at the time of implant placement? One very important thing, please, when you read studies in general, not only my study, read the details. Because if you only read the conclusion without seeing the details of the study, you may make a wrong judgment. And I'll explain to you why in a bit. So here, thanks for Dr. Ryan, my friend, for these nice illustrations. This is the one side that received the osteotomes, osteotomy done, leaving 1 millimeter of residual bone, and place a Nova bone and place the implant. Then the other side that received the osteodensification drills, the Versa drills, exactly the same, following their recommendations for the sinus augmentation for the when you have 5 millimeter residual bone. So what I'll show you now is, I want you to look at this one where we have a broad, nice dome-shaped elevation, as you can see in the picture. We have a wide sinus from the medial wall to the lateral wall, and we have an angulation of the sinus floor that is not acute, okay? So we have more of a flat sinus floor. So that allowed us to get that, what we are seeing in this video, and that's how the procedure was done and how the video recording was done, that we can see that having that anatomy will allow us to get more release and get that dome shape, and having less problems and less chances of perforation, okay? In addition to that, Nova bone acts like a nice cushion that allows to expand the sinus membrane and give us that kind of like that dome shape. And I'll give you more cases as we're going, and I'll explain more about that. So here you can see we elevated, placed the bone, got the implant, everything's looking good, no perforation. Meanwhile, on the other hand, this is a side where the sinus may look narrower than the previous one, and we have an acute angle of the sinus floor. So we did not have a perforation at the time of the drilling, and here we were using the osteodensification, the Versa drills. And we did not have a perforation at the time of placing the Nova bone. But I want you to see and focus what happens at the time that implant is being placed. And if you take a CBCT, or if you take a periapical x-ray after the procedure, you're going to be happy that you have that nice dome. You're going to be happy that CBCT is looking good and we had no perforation. And I bet you if I also took a CBCT for this cadaver head, I will not see the perforation. But look what happens clinically as the implant is coming in. Here we go. We perforated. Now, is this going to cause a problem? Maybe yes, maybe no. We pray that there's no problem going to happen. But what I want to allude to is that you may get a perforation and you're not aware of, okay? And that's what I call it, a localized vertical pattern instead of a widespread dome like we've seen in the case before. So results, read them very carefully. We have 40% chances of perforation when we use the osteodensification with the osteotome technique, and 50% with the osteodensification technique. So if you stop right here, you will be surprised, like, oh wow, this is a very high percentage for perforation. But now let's look back at all the other studies that have been done. We're around the same number. The problem is we cannot, in reality, detect these perforations. That's why it's underreported. So let's read it further and see what does that result mean. When we look at the timing, most of the perforations happened at the time of implant placement. And this is very important because what's happening is we have 5 millimeter of residual bone. We're trying to place a 10 millimeter long implant. How much do we need to lift? Do we have to lift 5 millimeter or we have to lift more than 5 millimeter? Most probably we have to lift more than 5 millimeter because if you lift 5, the tip of your implant is right at that edge of the sinus membrane that you've lifted. In addition to, with the osteodensification drills, one of the downside to it, there is no way to know how much you've lifted. Unless you finish the lift, you take a scan, you measure, and that's how you can tell. But during the procedure, clinically, you don't have that luxury of measuring how much you lifted. So a 10 millimeter implant in a 5 millimeter residual bone means I may have to lift 7 or 8 millimeter vertically to place that 10 millimeter implant. So that's a lot of lift that we have to consider. So when I look at the 40% or the 50%, those did not come from the actual osteotome or from the actual versadrills themselves. That percentage came from the implant placement, and that's where that percentage from, because 10% of the sinus is perforated at the drilling when we look at the osteodensification drills, the versadrills. So 1 out of 10 cadavers only perforated, and 2 out of 10 perforated with the osteotome. And when we placed the bone graft, the Nova bone, we had 0 perforation at all times for all of them. So I've been talking forever. What does that mean? So here's what I say and how I manage my crestal sinus augmentation. I look at the residual bone height. If I have 4 to 5 millimeter of residual bone height, that is the kind of like the gray area, okay? I look at the sinus floor. If it is less than 30 degrees and I have narrow sinus, I go for a lateral window approach. Or if I want to crestal sinus approach, I have to be ready to manage perforation, either within the osteotomy, and I'll show you how I do that, or you have to go for a lateral window to fix it. Or the other option, instead of using a 10 millimeter implant, you can use a shorter implant with no bone graft. Now, if I have 4 to 5 millimeter, but the sinus floor angulation is more than 30, so I feel more comfortable nowadays with the osteodensification drills and the Nova bone to go with a crestal approach. Because the chances of perforations from what we know up to now are less. And if a problem happens, that osteotomy that the versadrills created for me will give you more chances to see that perforation. In addition to anybody who does crestal sinus augmentation, I recommend that before you know how to do crestal sinus, you have to learn and be able to do a lateral window. Because if any problem happens, you need to be able to manage it and repair it. So 6 millimeter or more, no brainer, we're going for a crestal approach. And if you have less than 4 millimeter, most of the time I'm going to a lateral window unless proven otherwise, which means if I have a really flat floor, wide sinus, and I want to go, and I'll show you some cases, I want to go for a crestal approach, I can try. If any problem happens, I can always fix it. But this is generally like a safe zone for me when I'm doing my planning. So what options do we have for grafting? We can do autogenous, same patient bone. We can use allograft, donated bone. We can use some xenograft from animals. We can use synthetic, and that's going to be our topic today, the Nova bone. We can use PRP and PRF, and some they use nothing. It's an option not to place bone graft, but it depends on how much you're lifting the sinus. But generally speaking, I like to place bone unless I have a perforation and I'm going with a shorter implant. So let's talk a little bit about the Nova bone. So it is a calcium phosphosilicate, which is a synthetic material. It's a bioactive glass with silicate backbone. Okay, it's combined with calcium and phosphate, and it gives that composition of a natural bone. When that calcium phosphosilicate contact with fluids, it will give us some bioactive response, which include the following. We get a formation of hydroxyapatite-like layer on the surface of the particle. In addition to, it releases the ions of calcium and phosphate, and that stimulates osteogenic cell activity. This is important. So Nova bone is an osteostimulant, and we will talk about what an osteostimulant is. And last but not least, it promotes the mineralization of the bone and collagen formation. And they added some additives like polyethylene glycol and glycerine, and those they fill the spaces between the particles and enhance the handling of the putty. It makes it it's a non-toxic material, and it's water soluble. So this is mostly for the smooth surface of the putty and the handling of the putty. So the putty has osteoconductive properties for space maintenance, acting as a scaffold. It has osteostimulation effect, which is going to stimulate the osteoblasts, proliferation, and differentiation. Then what is osteoinduction that we know? The difference is that osteoinduction, it stimulates osteoprogenitor cells to differentiate into osteoblasts, which then will form new bone. But the osteostimulation, they're actually stimulating the osteoblasts themselves. And that's what Nova bone does. And there are some references for whoever would like to read more about the osteostimulation that the Nova bone gives us. So that bone is available could be in a clamshell, in a tray, could be in a syringe or a cartridge. Cartridge is the most preferable that I use for the crystal sinus augmentation. And this putty can be, or this bone graft, the Nova bone, has been used, and there's literature on using it for socket preservation, for sinus augmentation, for intrabony defect, to fill around implants with immediate implant placement. A lot of applications that it has been used to, but today I'll focus mostly on the crestal sinus augmentation. So as I mentioned, it's synthetic, it's non-toxic, osteostimulative, osteoconductive. You do not need to put it in the fridge, but make sure it's not in your car. So if you live in California, you live in Texas, Florida, be careful. You don't want to burn that out. You can combine it with autogenous or allograft, and it's very, very easy to use. So there are two studies. My good friend George Kotsakis is part of those, where they look at using the Nova bone as a protective cushion as they're doing the osteotomy and as they're using the osteotomes to lift the sinus, and that minimized the risk of perforation as they were doing the sinus augmentation. And this is another study also where they're having the hydraulic pressure from the Nova bone help lifting the membrane. And this is what I do and what I mostly aim to get out of the Nova bone, that pressure that the Nova bone will give me to lift the sinus membrane. So let's discuss some clinical cases. I'll try to go through this quick. I've been talking a lot. I'll make sure that I focus on the clinical stuff. So here we have about almost 7 millimeter of residual bone, and no brainer. We're going for a crestal sinus approach, and we're using the osteodensification drills. And as you can see, clean osteotomy that you're able to see the sinus membrane. And this is when you go 1 millimeter below the sinus floor, and then we place our implant and we suture to primary closure using our glycolon sutures. And this is the final. So we place the implant, we have that nice dome, and we have that lift. And this is 3 years later. We see that we're still maintaining this pace, and you can see turnover of the bone almost looking like the natural bone that is surrounding. Another case where it is on a slope, And those are harder when you go to treat crestal sinus augmentation over a slope. And we do the osteotomy, we place the implant, we place the nova bone, and this is the day of the placement. You can see that we have the nice placement, the nice bone, and that nice dome. And at 6 months, just look at the periapical x-ray and that turnover of the bone. I'm not saying at 6 months you're going to see complete turnover, but we see on the x-ray, just from the x-ray, a nice turnover for that bone. So this is a case where I may have a 4 millimeter off residual bone. But this is the one that I told you, yeah, you may go for a lateral window, which could be 100% great and true. But when I look at the sinus floor angulation, this is almost a flat sinus floor. And I feel more comfortable to try to go with a crestal approach with this one. And if any problem happen, I can always go to the lateral window and fix that perforation. But I'm comfortable with this more than a case with the sinus floor angulation with an acute angle. So we go in, we do osteotomies, and you can see the nova bone putty inside the osteotomy because we placed it and then we placed the implants. And this is what I do. So generally speaking, I use the osteodensification drills for all my crestal sinus augmentation. I use the drills a little bit different than what they recommend. I break the sinus floor with the very last drill. I don't break it before the last drill. In addition to, I do not extend the drill more than 1 millimeter beyond the sinus floor. And afterwards, this is what I do. I use sinus curettes, the DAS kit from Dentium, whatever you want to use. I go and try to break as much as possible off the seal between the sinus membrane and the floor. Exactly like how I showed you in the sinus endoscopy with the Yamada technique, how he does that. Now, my only problem with the Yamada instruments is that they're very thin. I feel if they were a little bit wider, it may decrease the chances of perforation. Hopefully, after this seminar, I'll get any of the companies to sponsor doing some instruments for me to do that. But I try to break that seal. I do not want you to do the lift with this instrument. You are just breaking the seal 360 as much as possible, and then allow the nova bone to do the job next. That putty will act as hydraulic pressure that helps us raise that sinus membrane, okay? And when I place the nova bone, I initially use the osteodensification drills to introduce it, but then I switch and get the osteotome without any pressure, just with my hand to try to push that bone in and get more condensation of that bone. So you can see here, this is the periapical x-ray before placing the implant, and we place the implant. We go for primary closure. Later on, comes back, we do the uncovery. And this is the CBCT looking after the implant was placed, and we have a contained graft, and we don't see any particles flying around. Now, again, that does not mean that there's no perforation, as I told you, but most probably sinus looks clean, looks clear. This is a couple of months after, so we should be good. So this is immediately at the day of, this is 6 months after the crown was delivered. And you can see that change in the density of the bone from where it started to where we at today. Now let's look at another one where we had to extract this tooth and the patient was not ready for immediate implant placement. So we grafted, we use our Cytoplast TXT200 membrane, and we suture, and we come back later and we have 6.1 millimeter residual bone. So this is crestal sinus approach. But now let's look again at that sinus floor angulation. This is an acute angle, which we know now that I may expect perforation. So let's see what's going to happen. So we go in, We have nice regenerated bone. And we do the osteotomy. Everything looks good. We place the nova bone. We take periapical x-ray. We have a beautiful dome, everything looking good. And we take CBCT, everything looking good. Let me allude again to Dr. Abdul Karim Hmaidan's study. 60% is the accuracy of the CBCT. We started with this sinus floor angulation. Do you now see the perforation? Here it is. So we have a perforation that we were not able to see on the CBCT or on the periapical x-ray, but I know because I was the one who performed the procedure. So what I come up with in such cases is the waffle cone technique, what I call it. I use amnion chorion membrane and I use the nova bone, and that nova bone gonna look like a vanilla scoop of ice cream inside a waffle cone. That's why I called it a waffle cone technique. And I introduce that using osteotome into the sinus cavity and then place the implant and suture back. So this is after it healed, ready to be sent to the restorative dentist. Now let's show you last case where we extracted this tooth. We have huge palatal defect. We grafted it, we used the cytoplast membrane, and we come back later. This is what we have. Now, this one, all day long, I want to go for a lateral window. Patient is a little bit health-wise, a little bit compromised on blood thinners, and we have really, really thick lateral wall of the sinus cavity that is almost maybe as thick as the amount of the residual bone height. So I decided I will go through the crestal. Yes, I have a little bit of an acute angle, but I know that if I have to go for lateral window, then it is what it is. I was going to go to lateral window from the beginning, but now I'm trying to take my chances because I'm modifying this because of my patient, okay? So we go in, we have regenerated good bone, and we do the osteotomy, and now we can see the perforation, okay? It's a small one. So here, remember, I started with a maybe 4 millimeter of residual bone. The case before, I started with 6 millimeter of residual bone. So I feel comfortable to repair a 6 millimeter residual bone with the technique that I showed you and place a 10 millimeter implant. But in this case, I have a 4 millimeter residual bone. If I want to place a 10 millimeter implant, this means I have to push 6 millimeter or more off the limit to get that implant in, and I may increase the chances of perforation knowing what I know today. So we do the same technique, but in this time, I'm getting an 8 millimeter implant. So I avoided going to the lateral window, avoided going to the sinus from there, and that's what we've done. And this is the day off. And this is 6 months after. We can see a nice turnover of the bone and CBCT. We can see bone is contained. Everything is looking good. And we were able to get the implant in, save the patient more invasive surgery, and send the patient back to the restorative dentist. So post-operatively with crestal sinus augmentation, it's the same, not any different than what we do with the lateral window. It's just we see less complications, but the post-operative care is the same, from antibiotics, pain medications, instructions, sinus care instructions about sneezing with mouth opening, no smoking and drinking. Good luck making them not to smoke, but it's recommended not to. I do not want them to exercise for a week. And my literature and behind that to say that they're going to be okay if they don't exercise for a week. I haven't exercised for 15 years and I'm still okay. So they should be good if they don't exercise for a week. Sinus decongestant is recommended if you expect a perforation. Do not drink with a straw. Do not blow your nose. Use all medications. So all of these instructions from soft liquid diet and everything that we would like to the patients to do. For the antibiotics, usually I place them on Augmentin unless they're allergic to penicillin, and it's metronidazole and clarithromycin combination. 3 times a day for the metro and twice a day for clarithromycin. You can put them on corticosteroids if you want. but it's not necessary unless you do like major GBR with it or something. But usually put them on steroids, chlorhexidine, mouth and ibuprofen, and acetaminophen, or if you want to give some narcotics for those patients. So by this, I sum up the lecture. I hope I did good on time. I'm more than happy if you have any questions to reach out to me either by email or social media. And thank you again, Russ, for having me.
Yeah, thanks there. Appreciate the lecture. Great photos and great videos that really kind of give us some insight into what's going on with the crestal sinus lift approach. We do have some questions. Let me get over there to them. Okay. You mentioned this, but I think it's great. We get this question a lot at Osteogenics, but how do you determine how much NovaBone to use? Is there a general rule of thumb or general guide on how many cc's you should use based on how much lift you want to get?
Great question. I think I've seen it one time. If you want a 5 millimeter lift, use the whole 0.5 cartridge of the NovaBone. So kind of like a millimeter for each 0.1 of NovaBone. This is kind of like what I run by. But generally speaking, if you're lifting more, you want to have more of a cushion. That's how I think about it. I want that cushion in order to help me reduce the chances of perforation as that image is coming in. Because if I have not seen one when I'm drilling, most probably if one going to happen, it's going to happen at the time we place it.
Yeah, so understood. And I think
lift, the whole 0.5 cc of the NovaBone.
And I think that's a good rule of thumb that we normally communicate to customers that ask. And I think it comes directly from NovaBone, but exactly right. 0.1 cc's of NovaBone is usually good for 1 millimeter of lift. So you can use that just as your rule of thumb. Do you have any experience or do you have an opinion on the maximum amount of lift you can get with this crestal approach?
That's that's a great question. I mean, I'm usually I'm one of those where if I want to do a procedure, I want to make sure that that procedure is 7 out of 10 at least cases that I do. I can get that predictability, right? Now, crestal sinus approach. Yes, I understand there are some they saying, "Oh, we're throwing lateral window out of the game. We're everything doing crestal approach." I don't believe this is true. I still believe lateral window has a role. In a lot of cases, we do lateral window. How much I can lift? I mean, I showed a case that we may have lifted 7, 8 millimeter. But does this happen every day, every single case? No. As I mentioned, we look at anatomy. We look at the sinus floor angulation, the membrane thickness, the sinus width. All of these factors play a game.
Great. You mentioned the different places that do specifically socket preservation. Do you ever use it, or have you ever used it around an immediate implant that you've placed?
Okay, your voice was cutting a little bit. So the question was, have I used the NovaBone around immediate implant?
That's correct.
Okay, no. For NovaBone, all what I used it for was for crestal sinus augmentation. And I haven't used it around immediate implants, but I've heard others used it and they have good results. I haven't personally used it. The flow of that, or some of those friends who I asked, they like the flow of the NovaBone around that immediate implant to kind of get the bone as apically as possible. But personally, no, I haven't used it. Most of what I use it for is the crestal sinus augmentation. That's my experience with NovaBone.
Okay, great. Specifically about NovaBone, have a question about if you used NovaBone for socket grafting, do you have any experience in using it just for socket grafting? And if so, do you use a membrane? And if so, what membrane would you use over the top of it?
Okay, great question. I haven't used it for a socket. I know there's some literature and some research for socket preservation from George Kotsakis also about that. There are countries that they don't have allograft. They synthetic is an option, which I would definitely recommend. You can use it definitely. For the bone graft, for the membrane, some they say about that the consistency of the putty and how it is that you don't need or require to have a membrane. But as a periodontist, when I hear that there's no need for a membrane, I get scared a little bit. So, I always would like to have a membrane. Generally speaking, I use cytoplast membrane, the DPTFE. You can use collagen membrane if you have intact walls with good KT to start with. But if you have some soft tissue problems, you have some bony dehiscence, then I would recommend the cytoplast.
Understood. We're getting quite a few questions. Just really interested in the waffle cone or the waffle cone technique, and maybe some more details, or maybe go back over that technique. But just specifically the questions: do you
Sure.
pack the excess membrane on top of the bone when then you place the implant, or do you trim the excess before placing the implant?
Great. Great.
Can you just speak a little bit to that?
What I do. Sure. Here's what I do. So basically, what I'm trying to do is using the amnion chorion membrane, I'm trying to get all these growth factors that membrane has. And I use a large size membrane, 20 by 30 or 30 by 40, depending on how much residual bone you have and how much you have to travel. And what I do using osteotome, I push on the nova bone and I introduce that into the sinus. And at the same time, the edges of the membrane, I ask my assistant to hold the edges with a cotton plier. So I'm trying to kind of get that conformed shape of the nova bone inside the sinus with that membrane wrapping that nova bone inside the sinus cavity. And by having the edges to the side of the osteotomy, I'm confirming that everything is still contained. Okay. And as I get the implant goes in with a very low speed, and I go slowly and one at a time. What I mean, I go in and I stop. I go in and I stop. I allow that bone to go and expand in slowly without forcefully getting that implant in the osteotomy. Now, as your implant is coming in, guess what's going to happen to the membrane? It's going to go in with it. Those edges, they're going to go in, which is normal. But when I had them up to the crest, as the implant is going in, I know that those edges may go in maybe 3-4 millimeter. So you're still within the confined part of the residual bone, and everything should be contained by doing so.
Great. I think this is a good kind of question. Just generally speaking, what's the benefit of the Nova Bone Putty over just using bone particulate? Let's just say allograft particulate.
Good, great question. Now we have studies that looked at the biomaterials if you use particulate, that the particle size or the edges of the graft of the bone graft may perforate the sinus membrane. So that smooth consistency of the nova bone is what I like. So if you take it and dispense it on your finger, your bare hand, you will feel how smooth that is. So that's one aspect that I like about it, okay? And that's why I used it in my research, because I wanted to remove that particle corners, particle size, everything that related to the biomaterial to be a factor that could cause a perforation of the sinus membrane. Just think about it. As you're getting that implant in and you have bone particles, those particles may act as something that is putting pressure on the membrane, and those sides of those particles may perforate the membrane. Now, if you use really fine particles, then you may not have that problem, but you have to add a lot. In addition to that, this Nova bone is coming in one piece and same consistency. That allows me to put pressure on it and compress it, and that Nova bone will help me elevate the sinus membrane and get that detachment of the membrane on the sides of the membrane, like the case that I showed you. I'm telling you, I do not introduce the Versa more than 1 millimeter. Then I take it out. I use my hand instruments, and that only to detach 360. I'm not doing a lift through the crest. And then I get the Nova bone, and Nova bone does the rest. But remember, if you get to do that on a acute angle on the floor, you might not be as efficient and as successful as when you have a flat floor sinus cavity.
Great. What is your decongestant of choice in the case of a perforation?
So I ask the patients to use Flonase decongestant. It's over the counter. They can use that twice a day for the first week. It is normal. I tell them that you may see blood coming out. That's normal. The only time I'm concerned if there's any bone coming out or pus from the area or from the nasal cavity, that's when I would want to investigate more and see what's going on.
Great. Question here, and I can help if you need it, but do you find just pricing comparison of the Nova bone cartridges compared to an allograft or xenograft vials?
Then I may need your help here.
Okay. Yeah, I'll just say, I mean, Nova bone. If
Honestly, I don't remember the price on top of my head.
Yeah, the cartridges they come in various forms, but the most economical way to buy them is a 6-pack of cartridges, and if you buy them in a 6-pack, you pay about $80 for half a cc, and so then you can just compare that to your allograft, depending on what allograft you're using. If it's a combination allograft, it's probably going to be a little less expensive or right about the same. If you're using 100% cortical or 100% cancellous, the Nova bone cartridges are going to be a little more costly than that. The standard allografts. Just for everybody's information.
Yeah, but you're comparing how many the allograft. How many cc's are you comparing?
I'm comparing it's a half cc. Just say a half cc to a half cc, but you don't take into account the delivery system and all the added benefits, I would say. So
okay.
So have a participant just said they routinely achieve 5 to 7 millimeters of membrane elevation using the hydrolift technique, using saline. Just your general thoughts on that.
So I haven't personally used it, but what I know from the literature, this is a good technique, but it's I think more costly, more technique sensitive. But hey, if that's what they get, I'm telling you that hydraulic pressure, that's the concept that helps us with getting that elevation or that much of elevation with less problems and less perforation. And that's what I'm trying to achieve, but by using the Nova bone. So if they're achieving that with the hydraulic lift, perfect. Definitely we see that in the delivery research. But what I would like from them, go back and review your cases and reach out to me. If you see that you have a lot of cases with a narrow angle and you were still able to achieve that much of lift with no perforation, please share them with me because we can pull more data into what we're studying and what we're looking at.
Fantastic. We're going to end it there. We're 1 minute over time. Appreciate the answers, Dr. Alqadoumi. Great presentation, as always. Appreciate everybody joining us tonight. Want to remind everybody that you're going to get a feedback survey that's going to be sent out to you about 15 minutes from now. And once you complete that survey, you will get your CE certificate. So we always welcome your feedback. It helps us in planning future webinars, understanding what feedback you have, what you liked, what you didn't like. We plan on doing many more of these, and like I said, the feedback's valuable to us. Also, we need you to fill it out for us to get you in our system and get your CE certificate out to you. So with that, I'm going to wrap it up. Thanks again, Dr. Alqadoumi. Great job, and thank you everybody that attended tonight.
Thank you for having me.